So first we will go over the physiology, normal physiology. Bilirubin is actually a breakdown product of hemoglobin, which is broken down in the periphery, converted to bilirubin, carried in the blood. Now this is indirect bilirubin, which is insoluble, so it is bound to albumin. It is carried out in the blood. The hepatocytes scavenge this bilirubin, conjugate it and secrete it into the bile. So there is not much conjugated bilirubin in the circulation. Conjugated bilirubin is usually very low in the circulation. What happens when this conjugated bilirubin is not going down further? That will cause obstructive jaundice. So once the hepatocytes take it up, conjugate it and secrete it into the bile canaliculi, until then, if there is any problem, it is Dr. Praveen's headache. Once the bile enters the bile canaliculi, after that, if there is any obstruction to it, then only the surgeon comes into view. So the bilirubin is secreted into the bile canaliculi, then they form interlobular ducts, they join to form segmental ducts. These segmental ducts will then join to form the right and left hepatic ducts, common hepatic duct, common bile duct, and into the duodenum. So anywhere here, if there is an obstruction, then it becomes a surgical issue. Even then, in today's world, we will call Dr. Praveen only for most of the cases, because the instrumentation and the endoscopic means have improved so much. Previously, all these cases were handled by surgery only. So how do we differentiate what is medical jaundice and what is surgical jaundice? First thing, the direct bilirubin will be high. It happens in both cases. So the direct more than indirect means some form of obstruction is there. It can be at the cellular level, it can be at the ductal level. If it is at the ductal level, then alkaline phosphatase GGT will get elevated and an ultrasound will show dilated intrahepatic plus or minus extrahepatic bile ducts. So any patient with obstructive jaundice with an elevated bilirubin, the first step will be to get an ultrasound to see if there is IHBRD or EHBRD. That will also tell us at what level the obstruction is. So it can be within the liver or anywhere outside the liver, and we will see what lesions can cause this. So generally we can divide obstruction into intraluminal, intramural or extraneous compression. So intraluminal in the bile duct is just gallstones and sludge in whatever form. Stent block cholangitis is also caused by sludge obstructing the stent. Has anybody seen any other cause for intraductal obstruction of bile duct? There are some rare things. Ascaris worm can go into the bile duct. So I have also seen only one case. We were all wondering what, this was in All-India Institute, we were all wondering what to do because it's very tricky. If you try to catch it and the worm breaks, you can go inside the bile duct and make things more complicated. So we just waited for 1 or 2 days, did an ultrasound again, the worm was gone. Luckily for the patient, it resolved by itself. So the next thing, intramural or the wall of the bile duct, there can be a tumor and there can be a stricture, benign or malignant stricture. You will see those causes. Extraneous compression can occur from a tumor in the head of the pancreas. It can occur from a lymph node in the hilum. A secondary lymph node can compress the bile duct. There can be a large hepatocellular carcinoma in the liver near the hilum, which is compressing on the hilum. That can cause an obstructive jaundice. The more common thing that we see is a Mirizi syndrome. Okay, so whenever there is stones in the bile duct, the primary treatment will be an endoscopic treatment. These days, most of the stones can be tackled through an ERCP. You go into the bile duct, retrieve the stones, and then you can put in a stent. These stones are usually formed in the gallbladder and then they come down into the bile duct. So once we have cleared the bile duct, we prefer to do a cholecystectomy in the same admission. Unless the patient is a very frail old patient, anesthetic risk and all, then we leave them and see what happens. Otherwise, we will do a cholecystectomy the next day or the day after that. If ERCP fails, it is difficult because of various reasons, large duct, a large stone, or the access is difficult, there is a large periamphic diverticulum or something, then we have the older alternative, which is surgical CBD exploration. These days we do it laparoscopically. Once we clear the, once we hold the cystic duct, we can make a puncture either in the cystic duct or in the bile duct itself. Put our instrument, there is a colonoscope, or you can use a ureteroscope with basket, with balloon, go inside, retrieve the stone, flush it, and we can either put in a T tube, or we can leave the, these days we leave the endoscopic stent itself inside and close the CBD. Later on we can do an ERCP and remove the stent. The next thing is bile duct tumors for intramural components. Bile duct tumors, the commonest occurrence is at the hilum. 50% of the tumors occur at the hilum, 40% are lower down in the CBD, and there can be intrahepatic cholangiocarcinomas also. So whenever there is an obstruction, whenever there is a tumor, of course the treatment will be surgical excision of the tumor. If there is a lower down tumor, then it is treated by a Whipple or a pancreatic duodenectomy. The tumor is at the hilum, it requires a resection of this bile duct, but we have to give a clearance on the bile duct. So if the tumor is well below the confluence, we can just resect the extrahepatic bile duct and do an anastomosis. If the tumor is going into the confluence and higher up, then we have to clear the bile ducts on that side, which means we will have to include some form of liver resection along with it. So at that time, then we will have to plan how much of liver we have to remove, what will be left behind, what will be the vascularity of that, whether it will be adequate or not. So for lower down tumors, lower CBD, head of pancreas, lower duodenum, all put together, the treatment will be a Whipple's operation or pancreatic duodenectomy. So we remove this part, the whole thing comes out, and then you have a cut end of the stomach, opening of the small bowel and the bile duct. So everything has to be reanastomosed again. So you will have a pancreatic jejunostomy, hepatic jejunostomy, and a gastrojejunostomy. So once this surgery itself will take about 6 hours. The pancreatic anastomosis is the weak link of it. It can leak. 30% of the people will have some complication, some form of leak. 5 to 10% may need a re-exploration for a collection or a bleed. But in the end of the day, it is the surgical treatment which offers a 100% possibility of cure for pancreatic or bile duct tumors. Any chemotherapy will only be adjunctive. So then, like I said, hilar cholangiocarcinomas, depending on which side duct they involve, we will have to resect that part of the liver. Normally the left duct has a longer course, a longer extrahepatic course also. So usually the left side can be preserved, we will get a margin on the left side. The right side branches early, so the second order can be involved, and getting a margin on that side will be difficult. So usually they will end up with a right hepatectomy, and the caudate lobe, which is right behind, that will have very short ducts going right into the hilum. So usually the caudate lobe also has to be removed. So we have to calculate the volumes, whether the remnant liver will be adequate for this patient, and then proceed. So if there is an intrahepatic mass, the commonest intrahepatic tumor will be a hemangioma. The commonest malignant tumor intrahepatic will be secondaries. The commonest primary tumor will be hepatocellular carcinoma. Then there is intrahepatic cholangiocarcinoma also. So we need some tumor markers to differentiate. AFP will, if AFP is positive, it's a hepatocellular carcinoma. CEA for colorectal metastasis, CA19-9 for bile duct tumors, biliary tumors, or intrahepatic cholangiocarcinoma. All these tumors, again, the treatment will, for primary tumors of the liver, whether it's a HCC or a cholangiocarcinoma, treatment will be liver resection. HCC has a slightly better prognosis than cholangiocarcinoma. The post-operative adjuvant chemo will again depend on whether it's HCC or cholangio. Primary HCC, normal liver only needs follow-up. It's a cholangiocarcinoma, you will need adjuvant chemotherapy. Colorectal mets again is managed in conjunction with the colonic tumor. So depending on how big the liver tumor is, how much of liver we have to remove, Sometimes we plan on the same sitting, or sometimes we plan on different sittings. So when should we do a preoperative bile duct biliary stenting? So basically these patients are having jaundice, that much we know. So with jaundice can we operate? That's the question. Or how much of jaundice we can operate? The first question is whether the patient requires a liver resection or not. If the patient requires a liver resection, then it is better to bring the bilirubin to less than 5. Because the jaundiced liver does not regenerate very well, it does not function very well in the postoperative period. So any liver resection, whether hilar cholangioma, cholangiocarcinoma, hepatocellular carcinoma, or colorectal mets, wherever we need a liver resection, we bring down the bilirubin to less than 5. If there is no liver resection involved, like a pancreatic duodenectomy, Whipple operation for a pancreatic tumor, there we don't have to stent every patient. If the bilirubin is less than 15, some centers have 20, some centers have 15. If the bilirubin is less than 15, if the patient is well preserved and his nutrition is good, we can go for direct surgery. If the patient is nutritionally depleted, we need time to build him up, then definitely we will do an ERCP stenting. Let the jaundice come down, his appetite will improve, he will eat, nutrition will build up, and then we take up for surgery. If the patient is having cholangitis, then there is no question, it has to be drained, the infection has to be settled, and then only we do take up for surgery. So first question, whether he needs a liver resection or not, and second, what is his background status, cholangitis and nutritional status. So depending on this, we will decide whether to stent him or not. Again, for hilar tumors, ERCP stenting, if it is possible, well and good, but in many cases it is not possible, so we have to do a percutaneous biliary drainage or a PTBD. So here a duct, under ultrasound guidance, we puncture the liver dilated biliary duct and put a stent inside. If the stent goes inside, well and good, we can actually go into the duodenum also. Otherwise, we will just leave an external drain, wait for the bilirubin to come down. Like I said, we prefer to come down less than 5 before we take up for any form of liver resection, and we always drain the segment that we are going to leave behind. The segment that we are going to leave behind should be healthy at the time of surgery. So that segment we will definitely drain. Depending on the patient's condition, we may drain the other segment also. So what about benign strictures? Benign strictures are usually iatrogenic. The commonest that we see is iatrogenic post-cholecystectomy bile duct injury. We'll see that separately. The chronic pancreatitis process can sometimes involve the lower bile duct. This is where a lot of study was there for conservative management, for repeated stenting, multiple stents. Yes, it is feasible, but it is time consuming and the patient has to come for repeated procedures. And this is only possible provided the patient doesn't require surgery for the pancreas. If the patient requires some treatment or surgical treatment for the pancreas, it is better to do surgical correction for the jaundice also at that time. RPC is again a separate entity. It may involve one segment of the liver. So that means usually it will require resection of that segment and then a good hepaticojejunostomy. So now a word about CBD injuries. So my professor of surgery used to say, what is surgical obstructive jaundice? This term is waning out, but he gave a definition: an obstructive jaundice that either requires a surgical treatment or is caused by surgery. That is also surgical obstructive jaundice. The commonest thing is bile duct injury during cholecystectomy. Although the incidence has come down now, it is still there, it still happens, and we must know how to manage it. One of the cornerstones of how to manage it is classification of that. So there is a classification system for that. So type A, C and D will all have bile leaks. So A will be from the cystic duct or from the, that is any leak in continuity with the bile duct. So this means if we do an ERCP and inject dye, you can see dye coming out in both these cases. Here the problem is with the aberrant bile duct where the leak is from the liver side. So here in ERCP, when you inject dye, you won't see any leak, but one segment of the liver will actually not be seen in the ERCP. That means you know that the bile duct is intact, but the leak is coming from somewhere else, from the liver side. These type E involves complete transection. So again, complete transection can be complete cut with bile leaking, or it can be completely clipped. So the classical injury is where the anatomy is mistaken. The surgeon mistakes the CBD for the cystic duct clips and divides it. Once he divides the cystic duct, tries to dissect off the gallbladder, there will be one more duct. He doesn't know what it is, it's all distorted, so he'll put a clip there and cut that, take out the gallbladder. What will happen here is the patient will not have a bile leak, but the patient's jaundice will jump in 2-3 days to 10-15. So you know that the entire CBD has been clipped. If you do an ERCP and see, either the dye will not go up at all, there will be a complete cut off, or all the dye will be leaking out completely. So the most common scenario is where there is a difficult cholecystectomy, surgeon will place a drain and there is bile in the drain on the day 1. What do you do now? So now we have to go back and see. A leaking bile duct means it can be one of these 3. It can be leaking from the CBD side or it can be leaking from the liver side. A leak from the CBD side will usually be a large volume, leak from the liver side will be a small volume, and usually over the next 2-3 days it can keep coming down. So the commonest thing to happen is cystic duct leak. The clip on the cystic duct can give way and it can start leaking. Or the surgeon cannot identify the cystic duct during the surgery, everything is plastered, and so he places a drain and comes and there is a leak. What will happen here is, since the normal passage is normal, this leak will usually settle. If it doesn't settle by 5-6 days, then we can do an ERCP and stent the CBD so that the bile will preferentially drain through the CBD and this leak will settle. So when to do an MRCP? Usually for the first 3-4 days it's not required. You can see if the volume is increasing or decreasing. If it's decreasing, it can be managed conservatively. But from the surgeon's aspect, the patient will want to know what has happened, why there is bile in the drain and all. So usually they will do an ERCP and MRCP and see whether there is bile duct continuity or not, and whether they can identify where the leak is. So the next thing is you assess how much volume is leaking. If it's a small volume, it could be from the liver side, it will usually atrophy off, it will usually reduce and stop. If it is coming from the bile duct side and it is not settling, then we can do an ERCP and stent the bile duct. One important thing that we have to keep in mind is whether there is a duodenal injury also, so that you have to discuss with the surgeon what difficulty he had during the surgery, whether there is any suspicion of duodenal injury. In that case, then we will have to do additional tests to see what it is. We may need a CT to see if there is free air, if there is any contrast leak, and then plan accordingly. Jaundice, again plus minus. Like I said, if there is a complete clipping, jaundice will jump immediately in 2 days. If not, it is usually because of the drained bile which gets reabsorbed, some mild level of jaundice will be there. So once the patient, you know whether it is a type A, C or D. A and D, ERCP stenting, by the end of 1 week we would have stented the ERCP, we know what it is. By then, ERCP, if it shows a complete transection, that means the patient has got a type E injury or complete CBD injury. There, the thing is, the patient will finally require a surgical correction, which is a hepaticojejunostomy. So how to plan for that? First thing is we drain all the collections and make it into a controlled external fistula. The sepsis or infection inside has to resolve fully. Then only we can do a surgery. So complete drainage, and then wait for the duct to stricture off. Once it strictures, the bile radicals will dilate. We can see that on the MRCP. The patient can usually tolerate a bilirubin of 5 to 10. By that time, we plan an MRCP, see that the ducts are dilated, and then plan for a surgical correction. Again, ERCP stenting, like I said, it depends on whether the volume is coming down. If it is coming down, we can wait. So on table, if the surgeon recognizes a bile duct injury, what can you do? The first thing is, don't make it worse. So the best thing to do is just give a wash, put a drain and come out. You can explain to the patients that it was a difficult surgery, we couldn't identify the anatomy, so we have not proceeded further. That is better than worsening the injury. Bile duct repairs, hepaticojejunostomy is best done by a HPB surgeon in a high volume center or a transplant surgeon. So it is better not to attempt these things on the on table. So that being said about obstructive jaundice, I'll briefly touch upon my area of interest, which is hepatobiliary surgery in minimal access, both laparoscopic and robotic. I'll just show a few cases. So this was a large SPEN pseudopapillary tumor of the pancreas in a young lady. So I did a laparoscopic distal pancreatic splenectomy. So that is the specimen removed by a small incision. This was an adenoma of the liver, benign adenoma. This was a 32-year-old lady going for IVF treatment because of infertility. So adenomas are at risk for bleeding during pregnancy. So these things, especially since this lady is going for a precious pregnancy, this has to be resected before conceiving. So I did a laparoscopic resection, removed by a phalansteal incision, and she went back to her IVF treatment and then subsequently conceived. So this was a 70-year-old lady, well circumscribed tumor in the segment 4. Again, laparoscopic resection was done. She has come for follow-up now 1.5 years down the line. She is still doing well, no recurrence. This was a well-differentiated, well-circumscribed hepatocellular carcinoma. This was a huge hemangioma, giant hemangioma of the liver. So this is the tumor. So this green color is what is called ICG, indocyanine green. We use this for a lot of biliary and liver surgery. So it is again like bilirubin. It is taken up by the hepatocytes and secreted into the bile. So during surgery, we can time it accordingly and either see the liver or the bile ducts. For gallbladder surgery also, we can use this routinely. So again, laparoscopic resection was done, 18 into 12 centimeter hemangioma. So this surgery was presented by my PG in one of the conferences in this year's ISPBA conference, and he got an award for that. This is the robotic surgery for a large GIST tumor on the lesser curvature of the stomach. Greater curvature is easy to access laparoscopically. We can do a stapled resection. The lesser curvature is on the far end, so reaching there is difficult. So that is where the robot comes in to help. So robotic resection and suturing was done. This also got an award in another conference in Maharashtra. So this robotic Whipple, yes, it is feasible. Whipple being a major surgery, we only take selected patients for a robotic Whipple. The anatomy, patient habitus, duct, everything has to be conducive for that. So if this is conducive, then we can do away, instead of this big incision, we can just do away with a small incision, then patient will benefit a lot. This was a colorectal cyst. Again, a resection and robotic reconstruction was done. So this got an award in World Congress of Endoscopic Surgery 2024. So this is the most recent. Again, this is a collection of all the ICG cases. So this I'll be presenting next month in HPB conference in Korea. Has been selected for the best video award. All these videos are available on YouTube. If people have the time, please go see that and give your opinions. And my number is there for any doubts anytime.